Welcome back, everybody, to another episode of The Dude Nurse. I'm your host, The Dude Nurse. A lot's happened since we last had a chance to chat. We've got this crazy little infection, this bug called COVID 19, which has, essentially reshaped the entire world. So, yeah, lots of new stuff. But we're not going to talk about COVID 19 today. We are going to talk about hospice. I know, don't everybody get excited at once. This is everyone's favorite subject. Just kidding, just adding a little levity. So, hospice. At some point, when treatment does not work, like let's say a patient has cancer and he or she's gone through chemo and radiation or both, or they've had, surgeries to resect certain parts of tumors or whatever. There may come a point in time when that treatment no longer works. It reaches what we call medical futility. And it's just not with cancer, but that's just it's a very common one. Alzheimer's disease is another one. COPD, heart disease. There's lots of diseases that once they get to a certain point, they're terminal, which means we can't cure it. So then the focus becomes on more comfort care, or you might sometimes hear it said as palliative care. The thing about it is that hospice is palliative, but palliative is not necessarily hospice. And we'll talk about palliative care on another episode. So hospice has been around for, I don't know, 50 or 60 years. I mean, even longer than that, but as what we think of as kind of the modern day hospice. A lady by the name of Cicely Saunders from the UK. She had kind of started the first modern hospice, and lots of prominent physicians have, written books regarding hospice. But despite the fact that it's been around for some time, there's still a ton of myths that that clinicians such as myself face in hospice. Everybody thinks that we're all a bunch of Dr. Kevorkians and we're just trying to kill people, which is absolutely not the case. There are no states where that is legal. There are states that have the Aid in Dying, Death with Dignity Act, but that's a whole other topic, and there's only a few states where that is legal. But suffice it to say, hospice is not there to bump you or your loved one off. We're not pumping you full of morphine and just letting you die. And I'm saying this, I know it might sound crazy to some of you guys, but these are some of the things that I hear on a daily basis, when we, meet patients and families and talk about hospice. These are a lot of the questions that they have. They say, so are you going to kill my grandmother? And I, absolutely not. Well, is the morphine gonna kill her? Well, it could, sure, but it really kind of comes down to intent. We don't give the medication with the intention of killing anyone, but when a person has systemic disease, their bodies are not the same as they normally are. Medication isn't processed the same. Metabolism is all goofy and haywire, and we don't really know what's going on because we're not doing a whole lot of testing. So, which kind of leads me into my first point. So hospice is something that we, by and large, treat empirically. And what do I mean by that? So, if a patient has signs and symptoms of a UTI, we're going to treat for a UTI. We don't necessarily run a whole lot of testing. The goal of hospice is to keep the patient comfortable. And so, we want to start treating as soon as possible rather than running a bunch of tests and, kind of waiting for things to come back and see, kind of what's going on. Do we do it sometimes? Absolutely. So it's not that we don't treat things in hospice. We just we go away from a curative approach to a much more comfort oriented approach. There's a statistic, and it's approximately 80 to 85% of people, at least in the United States, would prefer to die at home. In other words, they don't want to die in some hospital bed, or they don't want to die in a nursing home. They'd like to die in the comfort of their home. And that is a benefit that hospice offers. It is covered 100% by Medicare. If you or your loved one has Medicare, you shouldn't have to pay anything out of pocket for hospice. That being said, hospice only covers what is related to the terminal diagnosis. And so I'll give you an example. So if you're on hospice with a terminal diagnosis of congestive heart failure, and you're on beta blockers, blood pressure medicines, cholesterol medicines, things like that, medications to manage fluid, like diuretics, hospice is going to cover that. But if you're also a diabetic, hospice isn't going to cover your insulin or your metformin or any oral medications that you take for your insulin or your COPD or whatever. Granted, yes, COPD is a terminal diagnosis, but it's all about what you're on hospice for. So if you're considering hospice, your hospice provider should be fully transparent with you regarding what will be covered and what will not be covered. So all of the nursing visits, chaplain, social worker, hospice aid if you need it, all of those things will be covered. You shouldn't get a bill for any of those things. So again, as I said, it's covered by Medicare. Commercial insurance policies can be a little bit different, but sometimes you might have to pay some deductibles and co-pays and whatnot, and that's kind of just dependent upon the type of insurance that you have. And your hospice provider, once they run your benefits, they can certainly tell you, what that is. And so a lot of people think of that quote unquote magic number in hospice is the 6 months. So it's like, okay, in order to come on hospice, I have to be dead in 6 months. Well, that's not necessarily true. I've taken care of patients on hospice for 8 months, 10 months, 16 months, 18 months. It's all about whether or not a person meets criteria. And it's kind of the opposite of what we see in just about every other sector of healthcare. Or, for example, if a person has a fall, they break a hip, they have surgery, they go to a facility for rehab, and in order to stay there and continue to utilize their insurance, they have to be, willing to participate. They can't just, every day when the therapist comes in to work with them, they say, I don't feel like it. I don't feel like it. I don't feel like it. Well, your insurance company's not going to just continue to pay, So in other words, you have to be progressing. But in hospice, we'll say, we have to see the decline, because sometimes patients might come on, they kind of had an event, something happened, and oh, we think it's time for hospice, and then surprisingly they stabilize, and we just can't keep them on hospice forever, and it's not the choice of the hospice company. It's CMS, or Center for Medicare Medicaid Services. They're the ones that dictate what these criteria are. They're the ones that tell the hospice providers what we have to do. So, a lot of times we'll get patients and families that are upset, and I'm not saying hospice companies don't make mistakes, but you know, we're just there to follow the rules, and this is what CMS says. And again, CMS, Center for Medicare Medicaid Services, these are federal regulations. So this is your federal government at work, folks. It's not personal. It's not something that the hospice provider you know doesn't want you on their service. They absolutely do. However, they cannot get reimbursed for the services they provide unless you meet criteria. Plain and simple. Um, I've heard a lot of patients say, well, I need you to, get me this, and I need you to do this and do that. And they want, all these things that aren't really covered under the hospice benefit. And, they have the impression that, oh, well, you're billing my insurance for all of these things. Well, no, not really. The money that the hospice companies get reimbursed has to do with the level of care that you are on. In hospice, there are 4 levels of care. The most common one is what's called routine home care. Okay, that's where the majority of patients spend their tenure, if you will, on hospice, is on routine home care. Another level is what's called respite. Respite is not for the patient. Respite is for the caregiver. So let's say, for example, uh, the son and daughter-in-law need to go out of town to a wedding, but grandpa's on hospice. He lives there at the home with them. Well, they can't just leave him, and hospice can't come in and sit with them around the clock. That's not what hospice does. So the hospice providers have contracts in place with skilled nursing facilities, assisted living facilities. There's a variety of contracts that they have, and so they will take and place grandpa in one of these facilities for up to 5 days. Medicare pays for 5 consecutive days in a calendar 30. So every 30 days from the last time you exercise that respite benefit, you can do it again. It's a really beneficial thing for the caregiver because it helps to prevent, what we call caregiver burnout. And, we'll talk about that in another episode as well. But one of the big things that caregiver burnout can lead to is, number one, as it implies, burnout of the caregiver. And then next thing you know, that's when we start to see the propensity for abuse kick in. You heard, just that one more time, for somebody to call you in the middle of the night to get up to go to the bathroom, and you haven't slept in 3 weeks, and you've got kids, you've got a job, and you just snap. So that's one of the things that we want to be able to prevent. So Medicare does cover respite. Okay. The next level of care, this is actually a higher level of care. It's called crisis care. So basically, you're on routine home care, and all of a sudden you're having a lot of pain or nausea, vomiting, or agitation, or anxiety, or all of the above. And, the general orders that we have in place are not working. So we need to get clinicians in there, and we might need to, spend some more time and work very diligently to get your symptoms under control. We might need to titrate medications, change out medications, increase the frequency of said medications. There's a lot of things we can do. So you'll see it written a lot as continuous care, but I really try to stay away from that word continuous, because a lot of times families hear continuous. That's all they hear. And continuous implies that it never ends. And that's not the case. I prefer the term crisis care, because once that crisis is over, and, if grandpa survives, if it's, not just a general decline and he's, getting closer and closer to the end, once his symptoms are maintained, then he resumes back to routine home care. Okay. And the last level and the highest level of care that's possible in hospice is what's called GIP, or General Inpatient Unit. And that's very similar to crisis care, except for crisis care is provided in the home. GIP patients go to a facility, and a facility has to have a registered nurse around the clock in order to provide general inpatient. So that would be the next step if crisis care did not work. Okay. So a lot of people, as I said, all they hear is, oh, continuous. That means you're going to stay here. Well, no. Again, as I said before, that's not something hospice can do. We cannot come in and, watch your loved one while you go to the store. We can't come in and, do your laundry and, lots of these other kind of things that people seem to have the misconception about, because that's just not what hospice does. Hospice is not a place where a person can just go and stay indefinitely and, until the end. That's not how it works. Hospice, the hospice team, hospice provider is always secondary, and the family, and if they're in a facility, they become primary. So it's their job, the family's job, to provide the day-to-day care. The hospice is there to basically oversee it and, make sure that things are going as well as possible. Make sure that the patient is as comfortable as can possibly be. We can, send out social workers to help with advanced directives. We can send out chaplains to assist with any kind of spiritual concerns. Typically, hospice chaplains are non-denominational, but that doesn't mean that, they can't get you connected with, a local Buddhist organization or Muslim or whatever the case may be. And you certainly don't have to have a chaplain. You don't have to have a social worker. You don't have to have a hospice aide. The only discipline that you cannot refuse is the nursing discipline. And I've ran into this a lot, especially with patients that, aren't so convinced about Western medicine. They want to try much more holistic approaches, and that's fine. Have no problem with that. But we cannot circumvent the nurse piece, because it's a CMS regulation that a registered nurse lay eyes on a patient and do an assessment at a minimum every 14 days. So that's not something that we can circumvent. I've only ran into this a couple of times, and or actually probably 3 or 4, but every time that I ran into it, it had to do with the fact that the patient was trying some sort of holistic approach, and it never worked, and so we ended up to hospice. So there's that. Hospice has, where the 6 months comes from, is hospice has the first benefit period is 90 days. The second benefit period is 90 days. There are an unlimited number of benefit periods. So the third and however many benefit periods subsequent to that are 60 days. And so what will happen then is, once you start entering the third or fourth or fifth benefit period, the hospice provider will have to send out an advanced practice provider, most likely a nurse practitioner. Sometimes MDs will do it, or DOs, which is another type of physician. But a lot of doctors just don't have time to make house calls, and the regulations do allow for a nurse practitioner. So these unlimited benefit periods are probably, I would say, new within about the last 30 years. It hasn't always been that way, but Medicare made some changes, I want to say, in the early 90s and started to allow these additional benefit periods. So hospice is not something that is all bad. It's not meant to hasten your death in any way, shape, or form. It is a phenomenal benefit. It allows people to stay in the comfort of their own home. There's always the saying, and I can definitely attest to this because, I got hospitalized a few years ago with like heat exhaustion. I'm in the Houston, Texas area. It's hot as hell down here, especially in the summertime, which we are coming up on, and I am not exactly happy about it. But anyway, I digress. I was out and about, not really paying attention to my body, not drinking a lot of water, and I ended up in the hospital for like 4 days with dehydration. I was on a low acuity floor, but they were coming in every 4 hours, checking my vital signs, drawing blood, doing this, doing that. Everybody and their mother was coming in and out of my room. I got no sleep. I was absolutely miserable. And I wasn't even that sick. It's not like I was suffering from, metastatic cancer. I mean, I can't even imagine how much worse that would have been. So there's an old saying, you go to the hospital to get some treatment, and then you go home to get better. The food wasn't all that great. And it's not exactly like you can kind of eat on your schedule. The nurses, they try their hardest to adhere to the schedules for getting your meds, but sometimes they have things that take priority over what you've got going on. They might have a patient coding in the next room. So my point is that sometimes hospitals can be very crazy and tumultuous places. Bells going off, buzzers and dinging, and other patients screaming, and all kinds of crap. With hospice, the team comes to your house in the comfort of your home. You can be in your favorite chair, your favorite recliner. And also the hospice provides necessary DME, or durable medical equipment. If you need a hospital bed, you'll get a hospital bed. If you need a walker, you'll get a walker. If you need oxygen, you'll get an oxygen concentrator. So, and all of those things are covered. They cover the DME, the durable medical equipment, which is the stuff, the aforementioned things that I was talking about. They'll cover supplies if you need what's called chucks to put in the bed in case you were to have an accident. If it comes a point where you need to wear adult briefs, or like for the ladies, the pull-up kind of panties for incontinence. They also cover various other supplies, barrier cream for your groin and perineal area, especially if you're incontinent. That can cause some pretty serious redness and chafing. It's not pleasant. They also provide the medications, as I said, but only the ones that are related to the hospice diagnosis. So, and again, they're sending the team out, so they're providing that support as well. So it's an amazing benefit. I've been doing this for a number of years now, and I really feel fortunate to be able to do what I do, and help patients and families when they're in their most vulnerable state. They've likely just gotten some very bad news, and it's life altering. All of a sudden, it's like, well, grandma just went in with a cough, and well, it turns out that cough might be because she has lung cancer, or a little bit of blood and in the stool, and maybe there's some colon cancer, or something going on. It could be something very serious. So, like I said, hospice provides a very necessary and a very amazing service. Um, I'll close with just some advice. If should it come time in your life, or someone you care about, a loved one's life, to where you need to explore hospice as an option, or you're considering it, you may say maybe you don't want to do chemo, maybe you don't want to do the treatment, whatever the treatment may be. Um, Make sure you ask lots of questions, because at the end of the day, never forget that these doctors, these companies, they work for you. That's your benefit. That's your hard-earned, uh, your hard-earned money has gone in and made you eligible for Medicare and whatnot. So you know, make sure you ask questions, and if you feel it necessary, then by all means get a second opinion, get a third opinion. Find out what other treatments may be available. And what I want you to take away from this, folks, is that the underlying message of what I'm saying just now, all these things, ask questions, it all boils down to you becoming informed and knowledgeable about your care. I'm not saying you got to go to nursing school, go to medical school, but learn, read up. There's a ton of resources out there, tons of resources. There's lots of support groups. There's a plethora of information and resources out there. If you choose not to educate yourself, then that's on you. But knowledge is power, and that is something that would benefit you greatly. I'm going to go ahead and close it out for now. Thanks so much for tuning in. Until next time, you guys stay safe. Take care of each other. Bye-bye.